Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today in the show, we have Leslie Farrington. She is a retired obstetrician gynecologist, and she wrote the Kevin MD article, "This Obstetrician Recommends Midwifery Care." Leslie, welcome to the show.
Thank you for having me, Kevin.
We'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
My parents were an interracial couple in the 1950s when that was illegal in many states. My father was a dark-skinned Black man. My mother was a white lady with blue eyes, and I came out looking white, basically. But my father instilled in me a strong Black identity. And those who are familiar with this, there's something called the one-drop rule, or if you have 1/8 African-American in you, you're considered Black. And culturally, I grew up in a Black family. Everyone else was obviously Black, and my mother sort of assimilated. And this was during the 50s and 60s when the civil rights movement was growing, and my parents experienced quite a bit of racism, and so the whole family experienced it. So I was pretty familiar with it. And even though my father did not have a high school diploma, he was self-taught about US history and how racism impacts the society, economics, politically, everything. So I learned a lot about this growing up. But I didn't think about it much during my career. I wound up getting married as a sophomore at Johns Hopkins University and having a baby 9 months later. And I was attending the midwifery clinic. They were training student midwives at Hopkins at the time. And giving birth with the support of a midwife turned me away from humanities and going towards the medical field. And my pre-med husband at the time said, "You don't want to be a midwife. You're not going to get a job." This was his perspective as a wannabe doctor. And so I wound up going to medical school at Howard University, knowing I wanted to be an obstetrician. And that was after 2 more babies were born. And so during my career training and throughout my obstetrical career, I was not thinking about racism. I was busy. But I did notice, and I was in a unique position to observe, many of the professionals, nurses, doctors, harbored prejudice. But I didn't recognize how that affected maternal health, and Black maternal health specifically, until it was part of the beginnings of the Council on Patient Safety in Women's Healthcare. That was started in 2014 because of the explosive news about maternal mortality in the United States was so much worse than the other developed countries. And what was puzzling at these meetings that I was attending with experts in the field, what was puzzling to them was, why were Black women dying at 3-4 times the rate of white women? And this was applied to well-to-do, well-educated, good insurance women who were not the typical patients you would blame for their outcomes, which was a very common thing for obstetricians to do, to blame the patients, especially Black patients. So the experts didn't understand why this was happening. But everybody I knew, my family, said, "Leslie, it's racism. Of course, Black women are having worse outcomes." And so I sort of went back to what I learned growing up, and I started to see how it was happening. So I decided to form an organization, develop a curriculum to educate the community, the Black community, as to how to speak up and get better healthcare. And our curriculum that we developed is called the ACT curriculum. Ask questions until you understand the answers. Claim your space, both physical and mental, trust your body, and tell your story. So we're about empowering, you could say, women, birthing people, and their supporters. Also doulas, midwives, whoever wants to learn to impart this curriculum to their clients. This is something that I'm promoting through an organization we formed called the Black Coalition for Safe Motherhood. And I formed the organization basically to promote the ACT curriculum. And over the course of putting this curriculum together over the past several years, I've been learning about the history of obstetrics and the history of midwifery, and how obstetricians, I didn't realize how young a specialty it was, how really young Western medicine was, in fact. So I've been learning about that, and that's what contributed to the article.
I want to touch upon one of the things that you said was about the prejudice of some of the healthcare professionals that you observed over your career. Can you give some examples of what you saw?
Oh, sure. So a nurse might come back to the nurses' station where doctors and nurses were congregating and say, and start talking about the patient that they were triaging on labor and delivery. You know, people come in with all kinds of emergencies. And if it was a Black person or a Latino person, they might say something like, oh, you know how they are. It wasn't necessarily explicit, but somebody like me would recognize, you know, that they harbored bias. There was also a tendency to label patients, especially Black patients, as poor historians, non-compliant. And if you think about some of the terms that we have in obstetrics, it sort of goes with the whole culture: incompetent cervix, failed induction, and other terms that don't come to mind that readily now that I've been retired for a while. But looking back and seeing the paternalistic and judgmental attitudes that doctors had towards, and nurses too sometimes, towards the patients, even white patients, you know, women would just don't get, the way I call it, the way I label it is, it's doctor-centered, not patient-centered or person-centered. And we know from the book from the Institute of Medicine, Crossing the Quality Chasm, that person-centered care is one of the 6 pillars of quality improvement. And that's something that's been ignored all these 20 years since that book came out. And basically, public health recommendations have been ignored, and assessments of racism in medical care have been ignored until recently. So, you know, the unequal treatment was put out by the Institute of Medicine also around 2001 or so. So then medical professionals didn't pay attention, you know. So what's been going on in public health, it's like in a silo. So that's why the obstetricians who were discovering these awful maternal health statistics didn't understand what was going on with their Black patients.
All right, let's transition now into the Kevin MD article that you wrote. It's titled, "This Obstetrician Recommends Midwifery Care." Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
Well, I decided to write it because there's such a lack of awareness of the benefits of midwifery in the United States. And there's a lack of awareness of the fact that in our country, 90% of births are attended by obstetricians. And in every place else in the world, the majority of births are attended by midwives. And so obstetricians took over the midwives at the end of the 1800s to beginning of 1900s, basically outlawing midwifery. And this is something that advantaged them and the hospitals that they worked in, so that all the women would gradually, because midwives were thought to be not as good practitioners as doctors because of the stories that doctors would tell. Plus, doctors were offering anesthesia. They would say that they're shortening the birth by using forceps. And so they supposedly were more educated. So this is what I wanted to expose, that this was the origins of obstetrics, that obstetrics is fairly new, that it was based on interventions and the pathologizing of birth, saying this was dangerous, that women were at risk, and so they should be in the hospital. And it essentially, that was totally untrue, but it took off, and it has become entrenched in the United States. But we've also seen some of the impacts of that, and that is increasing C-section rates. And to what extent, we really don't know. All of this intervention affects the outcomes and the statistics that we're now seeing.
Can you comment in general the relationship between obstetricians and midwives?
Well, in general, obstetricians basically wanted to put midwives out of business so that they could capture that business of birthing. And so there were virtually no midwives in the United States when we got to the 1960s. Midwives were looked down upon. They were not welcome on labor and delivery until maybe the last 20 years or so, maybe a little bit longer, but that's been very gradual. And the consumers of care, women in the 60s, 50s, 60s, and 70s started to look and say, hey, we need to get control of birthing for ourselves. We want to have more autonomy. They started to recognize that the interventions, the hospitalization, the medicalization of birth, if you will, was harmful and taking away from their experience. So they started to look for midwives. So midwives made a comeback, but it's hard to make a comeback unless you're a nurse and then certified nurse midwife.
Can you contrast the birthing process from a midwife standpoint versus an obstetrician standpoint?
So a midwife centers the patient. They are aware of the power that the vast majority of women have within their own bodies to safely birth their babies. So they're there to support the mom and do so in a way that empowers that mom. And they're there to deal with any issues that come up and to make sure the baby's okay. They're supporting the natural process, put it that way. They're supporting the physiology of birth.
And you mentioned one of the effects of obstetrician control, you say, over the birthing process. Is there data that suggests that it leads to an increased number of C-sections?
Oh, definitely. If you have support of doulas, care of midwives, you will decrease, and that's the key. And 80% of women are low risk and entitled to or should be able to access that kind of care. Then you're reducing C-sections. There's plenty of data there now. The problem is the public is not aware, and it's hard to increase the supply of midwives at this point when you don't have the collaboration that there should be between hospitals. There's not enough birthing centers. There's a lot of obstacles to being able to find a midwife, especially a Black midwife for a Black patient. And studies also show that culturally congruent care improves outcomes for Black women. So there's the answers to the Black maternal health crisis and maternal mortality in the United States overall is to increase midwifery care and to let the public know that you really don't need an obstetrician most of the time. But women are convinced that the doctor's better, and so it's going to take a long time before we can change this shift, make this shift happen to a more physiologic birth process that more women deserve to be able to access.
So from the patient standpoint, how much control do they have in terms of choosing a midwife versus an obstetrician for the birthing process?
There are many places in the country where there's a shortage of any kind of obstetrical or midwifery provider. So it depends on what part of the country you're in. In New York City, there's only, I think, one birthing center, so that those who don't want to birth at home but don't want to go to the hospital don't have many options. So we really need more birthing centers. And so I would like to see more. I would like to see obstetricians opening birthing centers and hiring midwives and getting this going. Take a leadership in this role if they really want to improve maternal health, and especially Black maternal health.
And is one of the reasons why midwives are suppressed in terms of their growth, is it purely in economics and the way our healthcare system pays for procedures?
Oh, the payment, there is a problem with paying for doula care, midwifery care. If you go to a birthing center and then you happen to transfer to the hospital, the birthing center loses out on the fees. Yes, there's lower fees for midwifery care, lower payments. So, and then the folks who would like to be midwives are often not as well to do as they need to be able to pay for school. there are many obstacles to becoming a midwife. And still, I'm happy to say that there's a movement in the Black community that women are following the path to become midwives and doulas in order to save ourselves. Some say SOS, save ourselves. So let's get more Black midwives, more Black doulas, and push for the Omnibus Act to be passed, which is sitting in Congress right now, that would address all of these issues that I mentioned. And obstetricians can learn to do a better job if they start to learn their history, start to look at what is evidence-based. Does everyone need to be on the fetal monitor? Electronic fetal monitoring is one of the main causes for increased C-section rates. And that was, even when I was a resident, I was told there's really no evidence of benefit for doing this, but they started doing it routinely for medical legal reasons. So putting people in bed, making them nervous, all of this becoming a patient, being told what you're allowed to do and not allowed to do. This is really, like you said, the word you use, controlling the birth, and that's not, it doesn't foster good outcomes. It fosters more C-sections.
We're talking to Leslie Farrington. She's a retired obstetrician gynecologist, and she wrote the Kevin MD article. This obstetrician recommends midwifery care. Leslie, where do you see this conflict going in the foreseeable future?
Well, because of the pandemic exposing racial inequities in healthcare and causing people to be sick, because racism makes people sick, and there's racism in medicine, and this is being recognized now by the American College of OBGYN. They have a strategic plan to eliminate racism in obstetrics and embed equity. And so does the American Medical Association. So I see changes at the top in terms of recognizing the problem. I hope that they will also recognize how midwifery would do to incorporate midwifery into women's health and to collaborate between midwives and obstetricians would improve for the chances that obstetricians would start to adopt the midwifery model to their practice, so that there will be plenty of providers who can support birthing people in getting their preferences and their needs and their values centered and having better outcomes and more joy and a spiritual experience when they give birth instead of a medicalized one.
And my final question, what's your take-home message that you want to leave with the Kevin MD audience?
Listen to your patients as individuals. Be a human and not just a doctor who's on automatic. Mindfully listen and center your patients. You will have a better experience in caring for them as well.
Leslie, thank you so much for joining me and sharing your time and insight.
Thank you, Kevin. Have a good day.